going down below the lumen of the cartridge, all these issues will be sorted. So, but I have not been able to solve it. So you can see now the haptic is looking down. That means it's looking towards the posterior capsule. One way of avoiding this problem is do a wound assisted insertion of the IOL. Don't go till the CCC. When we are injecting a Technis 1, an IQ or an IHANS, our cartridge tip is right at the CCC and then we are putting the lens into the bag. Here, one way to avoid all these headaches, what I showed you, is to start injecting the lens and your cartridge will be exactly at the lumen of the wound. And if you do that, then even if it goes down, it's not going to damage your posterior capsule. So this is what I have understood. But basically, conclusion, it's a brilliant product. Hold on to the plunger so that the air does not come. Size of the CCC in femto may be 5.25. I normally do a 4.9. Fill the bag with viscoelastic depending on whatever technique you're used to. Bimanual technique to implant the IOL, as I showed you, either with a Sinskey hook and iris repository in the other hand. Dialing the IOL, don't forget that the long surface area, so better could be that you just place the IOL. Viscoelastic removal from behind the IOL and in front of the IOL is necessary. In high myopes with larger bags, overall diameter may not be good enough. So if you have a very high myope and you have a bag size which is very, very big, this has a fixed plate haptic design. So sometimes these IOLs, if they are toric, may rotate. And this is very well known with the Zeiss lens, we know that. But IOL stability and rotation is very good. I've done some studies on the glerometer. I've also implanted the new lens which they're getting approval for, which is the Eden lens, which is the diffractive design and not a refractive design. The Lucidis is a refractive EDOF lens. Excellent results for distance and near. Thank you very much for your attention.
Thank you so much, and thanks for those surgical pearls, because these are really important because it's a different design of IOL than the routine hydrophilic or hydrophobics that we use. I would like to request Dr. Nitin to start the next presentation. In the meanwhile, sir, because you will be going a little early, so just a minute on what is your experience and about this IOL.
See, I will, nothing is honky-donkey in ophthalmology, so nothing is very perfect. So if I have to speak the truth, I've used about 350, not many, but some of them, okay, do complain like any multifocal IOL. Now theoretically, we are going to the diffractive to the refractive platform. So theoretically, we are going backwards. Our original refractive multifocal IOL was called Array. Some of you might have used the Array. Yeah, you would have used the Array. FDA approved refractive design, never did well in Indian eyes, and it was taken off the platform. As far as my results are concerned, yes, about 95% or maybe more are very happy for distance and reading. They do read N6. Some of them complain of halos while reading, maybe 2, 3 in 100. Then what is surprising is they say double, double, double. I just give an ad of 1.5 and the halos disappear. So I don't know why some of them are behaving like this. I don't know whether it's the pupil, because refractive IOLs are pupil dependent. Although we are looking at the pupil size, we are looking at scotopic, we are looking at photopic, somehow some of these patients are unhappy for reading. And I don't know whether the panel would like to share their, do they agree with what I'm saying?
Yes, I think perfectly. We'll move on to Nitin's presentation for lack of time. But just before, just one word about the type of EDOFs that we see. There are 3 types, though I missed the slide, I think. Yeah, he will be speaking. There is center near, center distance, and then asymmetric profile. So these are the things. So Lucid is the center near. That means central part is for near. So that's why these issues come with these